Thank you very much. Muchas gracias. I will just need the pointer. It is here. Perfect. Thank you very much. So good morning. I am so happy to be here. I am not going to give a masterclass. We are going to talk. We are going to discuss about cases. I think is really the best way to do that. Systemic lupus is a difficult disease, so I'm really happy to be here to discuss and know how you do things, because they are probably a bit different from the way I do things. So let's talk together. These are my disclosures. If you do not follow me already on Twitter, please be my guest. I have already said it twice. And I have to start by saying muchas gracias. It is for me an immense honor to be in Medellin. This is my second time, but my first time for the Colombian meeting. It is an immense pleasure to be here with you. So thank you, Mr. Chairman. Thank you to the organizers of the meeting. I think it's a great success. I'm going to say a few words about the pre-Congress meeting. It was supposed to be a secret, but I think 50% of people living in Colombia have received WhatsApps, images of me drinking margaritas. So we went to Tayrona Park for a few days. Is this okay? Okay. So we went to Tayrona Park for a few days, and I must say it was an amazing experience. It's a very wild area. So hopefully we did not see the big T-Rex. I would have been very afraid. But I have seen a much more fierce and terrible animal, is the Raptor. And just in case you see that kind of animal around in the room, be very careful. It is a very dangerous animal. I have to thank him for the high scientific content of this pre-course. Obviously what is crucial on the slide is not La Margarita, is the sunscreen. I'm going to talk about lupus. And I discovered that you have high-grade sunscreen, 80 FPS, which we do not have in France. So I know what I'm bringing back from Colombia. So that's the first thing. And I have also learned that you should never, ever trust Colombian guys to put sunscreen on your back, because they make little jokes when you are completely red. Now I have this written on my back. But I do love Colombia. Muchas gracias. So we're going to talk about a patient. Her name is Maria. This is not a true picture. Obviously, I'm not going to show you true pictures from patients. And she works in marketing. And for 3 months, she's been having some pains in the hands, inflammatory pain with occasional swelling. And she's working in marketing, so it's very bothering for work. And she also reports a rash on the face. But the main difference is that the rash is not new. She's been having the rash for a few months. And you can see that she's a very clever patient. She checked, and she comes back to you at the consultation, and she says, oh, I think this is lupus. So is this really lupus? Well, you know that to make a diagnosis of systemic lupus, we need clinical manifestations compatible with lupus. There are so many of these manifestations because this is a very systemic disease. But I'm sure you know that the number one manifestations is actually articular joint manifestations, and this is why we rheumatologists are well placed to take care of these patients. The second type of manifestations, more common, are rashes, skin involvement. So our colleagues from dermatology are also referring patients. I think this is a great way to work all together. Having clinical manifestations of lupus is not enough. You know, these manifestations are not specific. We need autoantibodies. This is obviously a very typical type of autoimmune disease. And in the case of this patient, you can see that she has normal CRP, which is quite common in SLE. Creatinine levels are normal, but she has very high titer anti-nuclear antibodies. And she has anti-dsDNA antibodies, again, at very high titers. So this is very typical of a typical lupus situation. But we should keep in mind that we have mimickers of lupus, things that look like lupus and are not lupus. And to be honest, when a patient with any rheumatic disease reports a new symptom, we always ask ourselves, is this new symptom related to the disease, in that case is SLE, or is this something different? And it can be very easy. I don't know if you are aware of this new classification, in type 1 and type 2 symptoms, but type 1 symptoms are objective manifestations. You have no doubt there is arthritis, there is a rash, there is serositis. This is objective. This is usually quite easy. It's more difficult with type 2 symptoms, and you know that type 2 symptoms are subjective manifestations, anxiety, depression, brain fog. How many patients report brain fog with lupus, and it's really difficult to manage. But it's also the case for pain. When there is no swelling, it's just pain. It can be really difficult to know whether there is something, not something. And among the most common mimickers, I'm sure you know that is skin mimickers. This is really, really common in systemic lupus. I just want to show you this slide. I'm sure you can guess the diagnosis. This is obviously not lupus, but I see 50 patients every year sent to the consultation because there's a malar rash. This is, you know, don't be shy. This is rosacea, of course. This is a very typical rosacea. So I know we have residents in the room. I think it's really important to know how to make the distinction. Because systemic lupus is a rare disease, even in Colombia. But rosacea is obviously very common, is 3 to 5% of the general population. So there are 3 secrets. The first one is topography. Systemic lupus can be anywhere, but rosacea is only on the face and eyes, but only on the face. Where it's somewhere else, it cannot be rosacea. Second element is the presence of pustules. Papules and pustules is typical of rosacea. You do not have that in systemic lupus, but you can have acne induced by corticosteroids. So it can be a bit tricky. And third is flush. I think that's the best way to make the distinction. A malar rash will stay for several days, several weeks, while rosacea is flushing. So I'm always asking the patients, are you getting red when you have an emotion, or are you getting red on the face when you drink a bit of alcohol? When the answer is yes, this is a strong clue towards a diagnosis of rosacea instead of lupus. And in the case of our patient, well, you can see the lesion. This is not lupus. So in the end, what we will say is that she has arthritis. She does not have a malar rash typical of systemic lupus. She has lupus-specific autoantibodies, and we have ruled out a very common clinical mimicker, which is rosacea. So I think it's really important to use this strategy. So what could it be? Well, this is lupus. You had no doubt this is a lupus session. This is not a big suspense. You notice that we did not use the criteria. We all know that these criteria are classification criteria for studies. They are not diagnosis criteria. But I think it's always the same. In your case and in my case, we always like to double check. So occasionally, we just take the list and we check. So if you want to check, we can do it. I remind you that the patient needs to have anti-nuclear antibodies to be able to apply these criteria. This is called an entry criteria. ANA has to be positive. It's the case. Second, you must have points from the clinical domain, and you must have points from the immunological domain. And this patient has both, so this is okay. And third, you need 10 points at least, and she has 12. So, well, we should not use these classification criteria for diagnosis, but if you want to double check, well, she fulfilled the criteria. It means that she could enter a research study or a protocol for research. That is okay. She's fulfilling officially classification criteria for lupus. Something that is progressively getting into medicine, but not so much in rheumatology, is digital tools. They are used in cancer research, in cardiovascular research, but not so much in our specialty. I see 2 types of applications. One is image classification. Computers, artificial intelligence are super good to classify image as yes and no. And so Chinese groups have developed a smartphone applications which enables to take a picture of a lesion and it tells you lupus or not lupus. Well, this is nice, but I don't have it in my smartphone. It's not available, and I'm not sure I fully trust fully the results of the study. Second publication, which I think is interesting, but I'm going to be a bit critical, it was published in ARD, and what is shown is that you can make a diagnosis of lupus in large databases of patients, national databases or your own registries, not just by looking for the code of lupus, but looking for signs of lupus. And what this ARD paper shows is that the more signs of lupus you have, the higher is the probability that someone has lupus. Well, this is known for 200 years. I like the little colors, the little thing, but I think this is not worth publishing in ARD. So I'm a bit suspicious about that. So I'd like to ask you my first question. Do you believe that these new technologies, big data, will profoundly change the way we make diagnosis of lupus or other rheumatic disease in the next 5 years? There's no correct or wrong answer. I'm just curious about your feedback. Who thinks, yes, it will change the way we do rheumatology? Okay, maybe 1/3. Who thinks it's not the case? We are still going to make diagnosis the way we do it now? Okay, not everybody is a believer of new technologies. Well, I like that. I don't think I will take a picture of one of my patients and you will say, oh, this is lupus. I really don't believe this is true. So can you tell me about the goal of treatment? So this is, again, a question for you. What is the main goal of treatment in systemic lupus? We have 3 options. Who believes the main goal of treatment is option A, remission? Please raise your hand. Don't be shy. Raise your hand. I'm not raising mine. Who thinks the main goal of treatment is to reach low disease activity? Interesting. Who thinks that option C is reasonable in a daily clinical practice? No clinical manifestation is enough. Please raise your hand. A few of you, okay. Oh, you've been brave. This is incorrect, but you've been brave. Thank you for participating. I will show you in a minute why it's not the case. So I actually asked the same question on Twitter, I think a few months ago, and you can see that a majority said remission, but many people also said remission, actually, and at least 25% said no clinical activity, and I strongly disagree. I'll show you why. So let's look at the PANLA recommendations. It's interesting because they are different from the EULAR recommendations. EULAR recommendations say that the main goal of treatment is remission, and PANLA recommendations say that the main goal of treatment is remission or low disease activity. So if you said A or B, you are correct according to these PANLA recommendations. And I think this is completely okay. And why is that the goal? Well, because being into remission brings amazing results. It reduces the risk of damage accrual, it lowers the risk of cardiovascular events, it even lowers the risk of death. So this is definitely why it's our main target. So, well, we all know that remission is the goal, or one of the goals, but what is remission is a complicated question. It's been asked in the literature for at least 20 years, and you can see there are dozens and dozens of proposals for definitions. So I'm going to show you one proposal, actually, is the latest one from the Doris group, to which I belong. I am not pretending that this is the correct one. Let's be very modest here. This is a proposal, and we're going to discuss. I'll show you why it's not so extraordinary. So this is it. You need 4 things. First, you need a clinical SLEDAI of 0, which means no clinical manifestation. I think you all know a SLEDAI. It means you, okay. But I can tell you that you can have a very severe case of lupus enteritis and a clinical SLEDAI of 0, because gastrointestinal manifestations are not captured by the SLEDAI. So you see that there are a few problems. Second, you need a physician global assessment of less than 0.5. The PGA is that you give a mark on a 0 to 3 scale when you see a lupus patient to measure disease activity. And I'm sure you can guess that if I ask each of you to give a number to the case I have presented, we will have 300 different answers, actually. So as a whole, it works, but it's not a very reliable tool. And what is really striking to me is that it is the only instrument for measuring disease activity that is actually recommended by EULAR. Can I ask you something? Can you raise your hand if you do a PGA for each consultation of each lupus patient you see? Please be honest, raise your hand. Well, we are all very honest. We are not doing it, and you can see that I'm not doing it either. So, well, what's the point in a way? So we know it's not well standardized. I have been privileged enough to work with Matteo Piga for at least 2 years. We've done a kind of international exercise to standardize PGA in systemic lupus. So this is published in a good journal. But what we agreed is that it has to be by people with training. If you, like this today, you put a mark on a scale, it's likely going to be not reliable. So I think this is not good. And personally, I think we can remove the PGA for the definition of remission. We need a maximum 5 milligrams of prednisone. And this is the explanation for the 3 guys who said C, why it's not correct. Well, if you have pericarditis and you give a patient 60 milligrams of prednisone, pericarditis is going to be cured, no clinical manifestation. But the patient will receive 60 milligrams of prednisone. So having no clinical manifestations of lupus is not enough to say it's remission. You obviously need no clinical manifestations and low corticosteroids. And what is low corticosteroids? Well, we're going to debate this in a minute, but we have data showing that more than 5 milligrams per day is associated with damage. So our target should be at maximum 5. Let's see if it's what is recommended. And of course, we need stable immunosuppressive treatment. If you are increasing the treatment, it is not remission. So that could be a proposal for what is a treat-to-target strategy in systemic lupus. You have active disease, you start treatment with the main goal of remission. If you reach remission, this is great. You will try to spare the treatment. If you do not reach remission, you go for low disease activity. And if you cannot, you need to increase the therapeutic pressure. We need to do more. At least it should be low disease activity or remission. I have to tell you about pregnancy, because we're talking about systemic lupus, and we know that we are mostly talking about young women. 95% of lupus patients are women, and the mean age at diagnosis, at least in Europe, is 30 years old. So pregnancy is a big subject. Well, despite a great improvement in the prognosis of pregnancy, it remains not so good. This is a study I really like. It's not mine. It is a Korean study that has been done in the full country. So all lupus pregnancies have been captured in a study. And what it shows is that despite improvement, despite the fact that South Korea is a good country, the rate of complication is still 3 to 9 times higher than the general population without lupus. So despite everything we do, pregnancy remains complicated. And we all know that being in active status when the pregnancy starts is not good. This is not good prognosis for the mother and not good prognosis for the fetus. But now we are smart enough to have new concepts. I talked about remission, I talked about low disease activity. So I have a question for you. Is it okay to start pregnancy in a patient with low disease activity? Not remission, low disease activity. Is this safe? What do you think? Who thinks this is quite safe? Please raise your hand. Okay. Who thinks this is not safe enough? We need remission. You are a majority and you are correct. Indeed, there is not a lot of data, but there is a study about 400 pregnancies, and it shows that starting pregnancy being in LLDAS and not remission multiplies by 3 the outcome of poor outcome for the female and for the child. So I think this is a very, very clear and important message. We need strictly remission to start pregnancy. And of course, life is what it is. We all are confronted to pregnancies in active lupus patients. This is common, no worries. So let's move on to the second part of the talk, the treatments. There have been lots of changes in the therapeutic strategies of lupus over the age. And I fully understand and acknowledge that some of these treatments are available in Colombia, and some of these treatments may not be available or difficult to find in Colombia. These are different world perspectives, I understand. We're going to discuss about that. But before, I'd like to start with hydroxychloroquine. Can you confirm that you have hydroxychloroquine in Colombia and not chloroquine? Is this the case? You have both, so it's the same as in France. And now the lab making chloroquine has stopped making it, so we switch our patients in hydroxychloroquine. It was used at the beginning, but now most of them have this. So we know the amazing properties. This is the magical drug of systemic lupus. It controls disease activity, it controls the flare. You have beautiful work, Manuel Gattegil, that you know, but there are lots of other properties. So what is really striking to me is that when you look at the numbers in publications, in cohorts, in real-life data, in trials, usually there is no more than 70% of patients treated by antimalarials. So 30% of lupus patients are not treated by antimalarials, and I do not know why, because I don't think that there is 30% of side effects. So maybe one explanation is that some people, when they add another treatment, such as methotrexate, on top of hydroxychloroquine, they actually stop hydroxychloroquine, and substitute that methotrexate? Because this is a question I've had quite often. So of course, we know that when we add something else, it is on top of hydroxychloroquine. I think we all agree with this. You've seen the papers for the use of hydroxychloroquine to treat or try to treat COVID with lots of patients dying from heart problems. So I don't know if this is a feedback you get from your patient at the consultation, but many of my patients said, I am not going to take hydroxychloroquine. I've seen TV and people die with this drug. I will not take it. So it's good to know about this study, which is published in 2022, so it's really recent. It shows that when you use hydroxychloroquine in RA or lupus at the normal doses, I'll come back to that later, we don't have an increased risk of death from cardiovascular manifestations. I think it's important to tell the patient that it's safe. Now is the controversial part. Which dose of hydroxychloroquine do you use? Again, there is no correct answer, no wrong answer. I'm just curious about the way you do it. So who does less or maximum of 5 milligrams of real body weight? Who uses this? Please raise your hand. Okay, who does B, more than 5 milligrams? So for sure I do that. Okay, who is using fixed dose? Who uses 200 milligrams? It's the majority. I don't think you can see, but I can tell you. 400? Okay, in France we use 400 for all our patients. I will show you why. Who does something else? What do? You change. Between 200 and 400. Okay, so it's good to know the international recommendation, which is indeed not to go above 5 milligrams per kilogram per day. But I think it's really important to know why there is this recommendation, because it's not based on efficacy. Look at the data from Europe. Each line is a different country. You can see that, well, it's very varied. In some countries, people use less. In some countries, people use more. What I want to show you is this. This recommendation of 5 milligrams kilogram per day is because of the retinol tolerance. When you use more than 5 milligrams, you double the risk of retinal toxicity. So it's really interesting because the recommendation is not based on efficacy, it's based on tolerance. And in the original paper I've just shown you, the risk of retinal toxicity is very high. It was almost 20% at 20 years. Let me ask you these questions. Do you have 20% of your lupus patients with retinal toxicity? I don't have that either. Maybe 5%. So I'm really happy to quote this paper published last year. It's a huge study. It shows that the real numbers are much less. Maximum is 5% at 20 years. So these are very reassuring data. But it shows that if you use more than 5, indeed, you double the risk of retinal toxicity. So this is why we have these international recommendations that we are very proud not to follow in France. I will tell you why. First is a baseline screening, and then is the follow-up screening. And the follow-up screening should be done every year after 5 years. And in France, we do that from the start because we like to spend money for nothing. I don't think this is very efficacious. Something very puzzling to me is the baseline screening. Do you do baseline screening in Colombia? Can you raise your hand just to confirm you do? In France, you do? Okay. Well, let me ask you this question. What's the probability of finding a pre-existing retinopathy in a woman aged 30 years old? 0. So we are doing this almost for nothing. It's still recommended, but for instance, in the British recommendation, they have cancelled this part. There is only follow-up recommendations, not baseline screening, and I think it's very reasonable. Beware, if it's a late onset lupus, someone with a diagnosis of lupus age, I don't know, 65, maybe it's worth it, but in a young woman, I think we are doing all this for nothing. But the follow-up is obviously very important. So I said the recommendation is based on efficacy data, tolerance data. Let's look at efficacy. What happens if you use 5 milligrams or less of hydroxychloroquine? You increase the risk of flare. So this is very fascinating to me, that the recommendation is based on tolerance and not efficacy. So you have to make your choice. Either you use more than 5 milligrams kilogram per day, you have less flares but more retinal toxicity, or you use less and you have less retinal toxicity and more flares. Well, my choice is to use more. Your choice is yours. Then the patient is asking us, well, am I going to take HCQ all my life? So for me, this is a red alert. Because we know that patients stop taking the treatments. And there are different reasons. Sometimes they cannot afford paying for the treatment. This is sad, but it happens. But also sometimes the patients are going better. So if I am going better, why shall I go on taking the treatment? This is quite common. There's a third explanation, which is to defy death. I am not taking the treatment. This is the proof that I am not sick. If I am sick, I have to take a treatment. Not taking it, I prove myself I am not sick. This is quite common, but very nasty. And what is really sad is when you look at the data, real data for therapeutic adherence, no more than 70% of patients are really taking hydroxychloroquine. I will tell you a secret, but you have to swear that you will not tell anybody outside of the room because it's not published yet. I captured for France, in the national healthcare system, all lupus patients, and I checked who went to the pharmacy to buy hydroxychloroquine. It's not good. 56%. So I'm pretty sure these patients have a prescription. They do not go to the pharmacy to buy hydroxychloroquine. Well, so at the consultation, I have this little slide that I show very proudly to the patients. I think you know lupus is the wolf, obviously. So I'm telling them, and I think it's very visual. Well, the treatment is the cage. You can stop taking the treatment, but we already know what's going to happen. And, well, it's quite visual. They like that. Yet, it does not mean that we have to go on with the treatment forever. Obviously, at some point, we have to stop. So let me ask you this question. When the patient reaches remission, are you decreasing or stopping hydroxychloroquine? Please raise your hand if you do this. Okay, I don't do that. Show you why. We had no data until last year, now we have. So we did a survey with one of our residents, and this is what we have in the room. 50% of people, doctors, go on, and 50% either stop or decrease. Well, this is understandable. Look at this ARD paper, I don't know if you've seen it. When patients have been in remission for 1 year, if you decrease the dose of hydroxychloroquine, or you stop hydroxychloroquine, you multiply by 2 to 3 the risk of flare. So I don't know for long-term remission, but for short-term remission, for sure we should go on with the same dose of hydroxychloroquine. Some message about corticosteroids. I'll be quite brief because we all know that it's super toxic and that less is more. The international recommendation is not to use more than 0.5 milligram per kilogram per day to start treatment, except if it's very severe. But let's be honest, I think we all know that sometimes we use 1 milligram kilogram per day of corticosteroids. We do not follow recommendations. What is really interesting is what is recommended for long-term use. EULAR says that on a long-term basis, we should not prescribe more than 7.5 milligrams of corticosteroids. And I told you, we actually have data showing that more than 5 milligrams is toxic, and we are all rheumatologists. We know that for the bone is not going to be good. For cardiovascular risk is not going to be good. So I don't understand this EULAR recommendation. There's also a paper showing that when the patients receive 5 milligrams of prednisone and that you stop the treatment, they make more flares. And I don't like this paper because my colleague from France actually is saying everywhere, but we should change our practice. We should not stop corticosteroid in lupus. We should go on forever at 5 milligrams. So he's not a rheumatologist, I must say. But I don't believe this is true. And hopefully we have a new paper published in 2021 showing that, yes, of course, stopping corticosteroid should be the target. If you stop progressively, you limit the risk of damage and you do not increase the risk of flare. So this is the main message. We need to stop when we can. We cannot always, but when we can, we need to stop. I'm going to be brief about conventional immunosuppressive agents. You know that in many symposiums we are talking about new treatments, but of course we have typical classical treatments, methotrexate, azathioprine, MMF. I'm not going to spend too much time because I prepared this summary slide just to give you all the indications that you can use. I think it's practical to have that in the pocket, but not spending too much time on that. Obviously we have new treatments, and there are 3 that have been licensed by EMA or FDA this year or the year before, 3 new treatments. The first one in belimumab, it was licensed since 10 years, 2011 in France. But there is now a new indication for lupus nephritis. So it's good to know that in a lupus patient with lupus nephritis, there is a theoretical indication for belimumab. There's a new treatment called voclosporin. It's not a biologic treatment, it's a tablet. It sounds like cyclosporin, and is the same family as anticalcinurin. It is approved for treatment of lupus nephritis only, not systemic lupus with other manifestations, lupus nephritis, and you see that it works very well. The magnitude of the effect is strong, it's 20 points, but I must say that in the control arms, corticosteroids were reduced very, very rapidly, and maybe this explains the bad response in the placebo arm and the magnitude of the difference. And then the third one, I'm sure you've heard about it, is anifrolumab, a blocker of interferons type 1. It works very fast. It's very spectacular on the skin. We don't have it yet in France. I think we will have it in June. And I don't know about Colombia, but I would be happy to discuss this with you. Not yet. Okay, so same as in France. It's quite spectacular for patient refractory. So again, I just made this little summary slide with all the validated indications, just in case you don't use this treatment every day, which is also my case. I don't use them every day, but you can just have a summary of how it's used in daily practice. We all know that developing new drugs is not an easy ride in systemic lupus. There are 25 drugs that failed, and just to quote the last one is baricitinib. I think we all know baricitinib. It's commonly used in, for instance, rheumatic arthritis, sorry. Well, it failed its phase 3 trial in systemic lupus, so the laboratory, the pharmaceutical company, is stopping the development in lupus. Question 2, how many drugs are there in the pipeline? Who thinks we have less than 50 drugs in the pipeline for lupus? Please raise your hand. Okay, who thinks we have between 50 and 100? This is big numbers already. Who thinks we have more than 100? Okay, the answer is 92. 92 drugs for a rare disease. So we are going to have 92 trials. So when I have one patient and I have 92 trials, how am I going to pick the trial to put the patient? And all these trials are based on the same criteria. So it's actually quite difficult to pick. I'm sure you've heard about CAR T cells. Have you had this question for your patients? Can I get CAR T cells? Has anyone had the question in the room? No? A patient at the consultation asking you, can I have CAR T cells for my lupus, for rheumatic disease? Okay, so you've probably seen the papers. You know that you take the T cells from the patients, you tweak them with a genetic thing to target CD19, you reject to the patient its or her hand cells, and actually, you've seen the New England paper, 5 patients completely cured from lupus, severe refractory lupus nephritis, able to stop the treatments. So this is really crazy, but I think is rare indications, refractory cases, is very, very expensive. But who knows, maybe in 10 years we will cure our autoimmune diseases with new strategies. We need new strategies, obviously. So what treatment are you going to give me? Well, again, little summary slide is always the same for the joints. Hydroxychloroquine, a bit of bridging corticosteroids at the beginning, and if it's refractory, methotrexate, azathioprine. If it fails, this is where we start with these new drugs, belimumab, anifrolumab, rituximab, which is more widely available. There was a talk just before about biosimilars of rituximab by Enrique Soriano, was amazing. So is there anything else we can do? Of course, there are other things we can do. Is the holistic management of systemic lupus. First is photoprotection. Can I ask you something? Can you raise your hand if you are routinely telling your patients about photoprotection? Everybody. Are you prescribing the sunscreen? So you put it on the prescription. That is amazing. You are an amazing audience because never ever everybody's raising their hands. So this is really great feedback. Second is tobacco cessation, smoking cessation. Can you raise your hand if you can do that in a very, very good manner and you make all your patients stop smoking? Oh my gosh, you're amazing. Okay. Because I'm always telling the patient, please stop smoking, but I'm not very successful to this. So I have a little secret. You know that skin manifestations are more common in smokers, and they are typically refractory to hydroxychloroquine in smokers. So my strategy to make the patient stop smoking is to say, oh, my poor madam, look at you. You are not so beautiful today. You should stop smoking. It is proven that it improves cutaneous lupus. It works very well, believe me. A cardiovascular risk, we all know it's raised, but there's a beautiful Lancet paper which measures precisely the increase in the risk in systemic lupus is almost 3 times more important than in general population of same age, and it's very, very high in young persons. You know that there are new EULAR recommendations, so this is a potential take-home message if you do not know. There's a recommendation for blood pressure in lupus, which is 130/80. This is new, it's been a year, so good to know. And I'll just finish about 2 tricky questions. The first one is this one. Do you know if cervical, vaginal lesions are increased in systemic lupus? Who thinks this is true? Who thinks this is false? Who has no idea? Okay. Well, let me show you the answer. So it is true, but I kept C because as medical doctors, I think it's always okay not to know as long as you know someone who knows. So, but it's not false. I'll show you why. Indeed, the risk of high-grade cervical lesion is multiplied by 9 in systemic lupus. And most lupus patients are telling you the same story. My dear doctor, I have already seen 36 doctors this year, and you want to send me to the gynecologist? Well, the answer is yes, you have to go and see the gynecologist before it's too late. High-grade lesions are multiplied by 9, so this is a very important checkup message. You have to be screened for that. And I'll just conclude with holistic digital management to talk about fatigue. My next talk in 30 minutes is about fatigue in lupus, but I want to show you something. Our thing is the same for you and for me. Dealing with fatigue during a consultation is really difficult because we don't have time and we have to do the prescription, clinical examination. So what we have invented with one of my interns actually is an automated computerized system. It's on internet. The patient answers questions, so you have questionnaires and it's in 3 languages included Spanish. So to measure fatigue, to measure anxiety, stress, sleep problem, physical activity, depression, and so on, fibromyalgia. And it provides automated feedback, so like advice online without any intervention. So this is very practical. I'll show you the results later. So this is my conclusion slide. I think the lupus management in 2023 has changed quite a lot. We should treat to target, and our main target is remission. And I think low disease activity is okay, but it's a plan B, it's not the plan A. Plan A is remission, because it protects from flares, it protects from damage, and for that, we need to prescribe hydroxychloroquine for all our patients. We all know that, but I showed you the numbers. It is not done. So we have to double check that the patients are actually going to the pharmacy, being treated with hydroxychloroquine. Limited use of corticosteroids, limited use of other treatments when needed, not too early, not too late, not to miss the window of opportunity. Manage comorbidities, fertility, pregnancy, do the iron monitoring, which is crucial. And I talked about the holistic management, for which we do not have the time in most cases to deal with, but I think is really crucial. Thank you very much. Muchas gracias. If we can keep the slide, the last one. Can you put it back? I think it's best to support discussion. The last one. Last one. Thank you very much, dear Chairman. Thank you.
Muchas gracias, doctor, por su charla.
Última.
Muy ingenioso. Armó toda la charla con un caso de lupus que si uno lo mira con cuidado a lo mejor ni lupus tenga, no sé. Porque tiene unas artralgias y unos sanas altos con un DNA, pero no tiene más nada. Lo de la piel era rosácea, right? En fin, nos tuvo entretenidos todo el tiempo participando y eso fue muy positivo. Entonces les invito a que hagan preguntas, comentarios. Arrancamos con, por favor, Natalita. Micrófono, por favor. Para el doctor Luis y luego el doctor Daniel.
Oh, it's perfect. Thank you very much.
Thank you. Right now. Okay, thank you, Professor Arnaud, for your excellent conference. Was brilliant conference. I have a concern, although you mentioned before, before women get pregnant, you're recommended to be on remission between 6 and 12 months. The majority of authors or experts recommend 6 months, but sometimes, for example, in the case of lupus nephritis, you're not feel sure about that recommendation. And how about in terms per month for severe manifestations? The women need to be on remission 12 months, 1 year. He had been suffering lupus nephritis or central nervous system disease, and probably these manifestations like arthritis, probably you accept 6 months.
Yes.
This has been explored, this statement.
I understand. Thank you for your question. So what I can say is that we do have these criteria for remission. They are validated, but I think they are not the best criteria. And it raises a difficult question is, how do we apply this to renal manifestations? Because obviously this does not cover renal manifestations very well. And there are at least 4 different societies, international societies, editing remission criteria for the kidney in lupus, and they are all different. So it's difficult to find which one is the good one. What we know from 2 randomized controlled trials is that if you reach a proteinuria of less than 0.7 or 0.8 at 1 year, you are relatively protected against bad damage in the kidney. So I think the best is to have, of course, no proteinuria or less than 500 milligrams per 24 hours. But in case this is not doable, 2 studies show that reaching less than 0.7 is protective against long-term damage and renal failure. So this is a practical way to answer your question.
Congratulations for your excellent conference. Thank you so much. Can you talk to us about a little bit about your experience with the use of belimumab in general in patients with SLE and also specifically in patients with lupus nephritis?
Okay. So I have no experience of using belimumab with lupus nephritis because the drug has just been approved in this indication and we have not treated any patient yet. The results from the literature are spectacular, but the magnitude of effect, 10 points between the 2 groups, is quite low. So I think there's a great question, which is, shall we prescribe this drug to all lupus patients with lupus nephritis or only in selected refractory case? And what's the benefit-cost-risk ratio? This has to be decided country by country because the costs are not the same. About my experience for treating belimumab, well, we follow a relatively large cohort of lupus patients, so we've treated lots of patients with belimumab. First is the good indication, for me, is refractory to standard treatment. I do not, never, ever prescribe a biologic in lupus if I have not checked that hydroxychloroquine is taken, and I verify this by measuring in the blood hydroxychloroquine levels. If it's 0, I don't go for biologic treatment. I say, oh, my dear madam, first, please take hydroxychloroquine and we'll come back later. Then, on top of hydroxychloroquine, I have to have some immunosuppressive agents, methotrexate, azathioprine, at reasonable doses, normal doses, and only if it fails, I use belimumab. The main issue with belimumab is its mechanism of action, which targets BLyS. It's a factor for the proliferation of B cells. It takes quite some time to act, usually a few months, commonly up to 6 months. And so when patients are covered with skin lesions, waiting 6 months is not okay. And so we are going to have anifrolumab, and I'm sure you've seen preliminary data. It works very fast, very strong, within just a few weeks or months, and some patients are completely cured with the lesion. So I suspect that for the joints, most people will go on with belimumab, and for the skin, I think most patients will start using anifrolumab in case of refractory forms.
¿Alguna otra pregunta?
Here. Thank you very much for your great presentation,
Thank
Dr.
you.
Arnaud. We want to know your opinion about those patients who keep low complement levels and persist with positive DNA, but no clinical symptoms that may afraid you to maybe enhance your therapy.
Thank you very much. This is a great question. I think the answer is in your question. When we see these changings, complement going down, dsDNA going up, without clinical manifestations, we do not change the treatment preemptively. We wait for the manifestations. Yet, it's not very robust, but it's of course a sign that something is going on. So usually I'm telling the patients, oh, you should be aware, your antibodies are rising, complement is going down, maybe a flare is coming. So double check the kidney more often and so on. Yet, some patients have, of course, low complement forever being very stable and low because they have a genetic deficiency in C2 or more commonly C4 levels. Well, there is nothing to do with this. And the best way to make the distinction is whether complement has been normal at least once. If it has been normal at least once and it's down, it's consumed. If it has never been normal, it's always low, well, either it's always active or either it's a genetic deficiency, and we can screen for that. We can ask for the testing of C4 genes.
¿Alguna otra pregunta?
Yeah.
Por favor.
Laurent, great and clear talk as always.
Thank you very much.
I would like to know your opinion about potential and new biomarkers. What do you think are the first line are coming biomarkers in the next years?
Thank you. This is a great question. Biomarkers and SLE. There are almost 90 biomarkers that have been used in different papers. There are around 120 papers about that. I am not going to talk too much about that because we have a talk coming right after that by our colleagues, so I do not want to tell everything about that. Just wait for the talk. It will be much better. We have a great speaker, so do you want to say something? Or?
Laurent, first, thanks for not having been a spoiler of my talk.
Yeah, no worries. My pleasure. You remember the Margarita ideas?
Yes. Secondly, I found very interesting the paper you mentioned about not stopping 5 milligrams of prednisone in long-term treatment of patients.
Yes.
What do you take into account when you have that patient that is in remission or low disease activity?
Thank you.
That you have him or her for in 5 milligrams. What do you take into account to downgrade or to keep?
I think this is a great question. So, shall I go on with 5 milligrams? Shall I stop the treatment? I think we should stop corticosteroids in a huge majority of cases when we can. And lupus is a difficult to treat disease, so we are doing our best. But I would be a liar to say that I stop corticosteroids in 100% of my patients, and this is definitely not the case. Well, I have no robust proven data to tell you, but I think that someone with a history of very severe lupus, we should definitely think twice before stopping corticosteroids. Someone with a history of catastrophic neurolupus, delusional something, I think it's quite okay to go on with 5 milligrams. It's the same with someone who had a very severe renal failure with proliferative lupus nephritis. Shall I really stop in the first years corticosteroids, or shall I go on for a few years? I don't know, but I am careful when there is a history of severe manifestation. Oops.
One more.
Yeah. Thank you, Dr. Arnaud, for your conference. It was excellent here. I know you said that hydroxychloroquine for all. I just wanted to ask you, when would you consider to step down the therapy if a patient is in remission for a long time?
So you're specifically talking about hydroxychloroquine?
Yes.
So what I can tell you is the data we have in the literature. The data are that if after 1 year of remission you stop or decrease, you increase the risk of flare. So for sure, the true answer is not before 1 year of remission. After 1 year of remission, we have no data. So let's be very modest. I don't know the answer to this question.
Okay.
But what I know is that this is a potent treatment and that my main objective is to stop corticosteroids, is to stop biologic, is to stop immunosuppressive agents. So personally, I go on with hydroxychloroquine at the same dose forever, screening for retinal toxicity. And if there is retinal toxicity, I have to stop. What I didn't show is that in the pharmaceutical company pipelines, there are small molecules, blockers of TLRs, 7 and 9, which is the main mechanism of action of hydroxychloroquine. So it's likely that in the next years, we will have some super hydroxychloroquine, super plaquenil, without retinal toxicity. But I am unaware of the cost of that. And what I can tell you is that in France, hydroxychloroquine per day is less than $1.
And just another question. Like, what do you think about giving hydroxychloroquine every other day?
Okay. So the duration, the half-life of the drug is very long, around 40 days. So you can take it once per day or twice per day, or you can do every other day. Then it divides the dose by 2. That's the way it works. If you use 200 milligrams every 2 days, it's the same as having 200 milligrams every day. I have shown you that in a majority of patients, you are underdosed. You will reduce the risk of retinal toxicity, but you are not in the window of maximum efficacy. So I would not do that.
CAR T cells has not been in the news in Colombia yet. That's why we haven't had that question from
Oh, yeah,
our
sure.
patients.
It's
Probably
a
in France it's more common.
Absolutely, it's a very
The
interesting
public
question.
domain.
But the way I solve this problem, indeed, is that I measure hydroxychloroquine in the blood. And we have ideas about the optimal target. It's not 100% proven, but if it's too low, I increase. If it's too high, I decrease. That's the best way to guide the treatment. It's also very helpful because when there is a flare, you can check whether hydroxychloroquine is taken or not taken. But our health system, what we have, this is life. In France, we have it very routinely. It's $40 US dollars to make the measurement. And it may not be available in many parts of the world, I understand.
Dr. Arnaud, being fever such a common symptom?
Fever.
Fever.
Yes.
Why is it so difficult for us to approach a lupus patient with fever?
Oh, yeah.
And what is your experience in terms of infections, TB, fungi?
So thank
that
you
sort
very
of
much.
things?
It's a great question. I see many mechanisms through which we can have fever in lupus. One is infection. This is the #1 cause of death in systemic lupus. So we are always concerned about fever, but it can also be disease activity. And the reason is quite simple. You know that a big part of the immunology of lupus is mediated through interferons, interferon type 1, interferon alpha. And usually these interferons, we have them to fight against viral infections. And in viral infections such as the flu or the COVID, we have fever. So this is the mechanism of fever in systemic lupus. It can be associated with severe complications, macrophage activation syndrome. So obviously we have to distinguish between infection and activity. It's not always easy. Let's be very modest here. There are some scores published. I don't think they work at the patient level. Maybe they work at the population level, but not at the patient level. I think the common strategy is to rule out an infection, doing routine examinations. And if really we are very unsure and it's severe, I think in some cases people will use IgIV to modulate disease activity without using immunosuppressive agents. But this is very tricky, and I can't answer in 3 seconds for sure.
All right, thank you very much, sir. ¿Alguna otra pregunta
Here.
antes de...? Okay.
Thank you very much,
My
Doctor,
pleasure.
for
My
your
pleasure.
very comprehensive revision.
Thank you.
And I have a question that I think so many of this launch may have. Does the ex-lupus patient exist? Ex-lupus. I mean, we have some patients that 20 years ago had a very severe episode of lupus, and nowadays they are anti-DNA negative, anti-nuclear antibodies negative. The patient is feeling well. Do we name this patient ex-lupus patient, or you have a lupus persistently in remission, or what kind is this?
This is where I know you are a true clinician, because you obviously see patients and I have the same patients, but I think you already know the answer to your question, actually. These patients, I can't say ex-lupus, but they are inactive, and that is what matters, actually. So you can call it remission, but for me, remission would be more in the beginning. You can always say it's a 30-year remission, but some of these patients, the antibodies do disappear. So I believe these patients exist. I have no name for that, but I see the same patients as you see.
Thank you.